Today we're going to be talking about spirituality and end-of-life care and the role of the volunteer, of course the chaplain as well, but the role of the volunteer in that. So in the beginning, let's talk about this issue of the difficulty of accepting death in our society, because we have a very death-denying society that we live in. And this wonderful quote from Elizabeth Kubler-Ross, she says, "It is difficult to accept death in this society because it is unfamiliar in spite of the fact that it happens all the time. We never see it." And some of you may have seen someone die, maybe a family member, but a lot of people haven't seen death actually occur. But it is a reality that we all face, and it has no determined time. We know that some people die suddenly, and not in the kind of order that we think that should happen. Had someone recently whose son, 30 years old, died of a heart attack. That was not a patient, but a friend of mine. And, you know, how do you make sense of that? How do you possibly make sense out of a 30-year-old having a heart attack and dying? But the young die just like the old die. Death never seems to discriminate between class or culture or race or gender. And we often call, you'll hear this term a lot in hospice, but death as a journey. And for some, it's a journey of fear, and some, it's a journey to deny, and some, it actually is a journey in which they welcome. So how do we define death? Well, death is defined by Webster's dictionary as a permanent cessation of all vital functions, the end of life. So basically they're saying, you know, when that final breath and heartbeat occurs, that's what they're talking about. Talking about it in very physiological terms. There's also a theological definition. Death means separation. The Christian teaching would explain death as separation of the physical body from the human being's spirit, which in Christian tradition, the spirit is the essence of that person. And so maybe you would think of it as mortal life and then eternal life. That's a very Christocentric kind of theological view. I'm sure that there are other theological views, many others. A pragmatic definition would be death is separation from this world as we know it. So separation, you know, from our families and from friends and from acquaintances and from earthly activities. So just a very pragmatic way to define it would be separation from this world. And so what is death to you? How do you look at death? What is death to you? Is it a journey? Life is a journey and death is a part of that journey. That's certainly the way that I've come to understand it. Some people see it as a celebration, a time of leaving the earthly realm for a spiritual realm. Some people would describe it as a new beginning. So I'm interested to hear if there's anyone who is listening who would like to comment about what their view, what is their, how would they define what death is for them? Is there someone with us today that would want to share? Well, the main thing that we need to understand, especially as volunteers, is that, well, really, all of our professional staff and volunteers need to understand this, and that is the patient's view is the priority. So we can have very, very clear understandings about how we view death. And that's fine for us to have those views. And if someone asks, well, what do you think about this? It's okay to talk to them about that. It's not okay to try to impose your belief on that person, but it is okay to share if they want you to share. But the important thing, I believe, is to sit in that space, that wonderful sacred space with the patient, and to find out what their view is, their understanding of death.
I have a question.
Sure.
I know that confidentiality is so crucial to this work. And I know this is really, it's deep, important work we are doing. I wonder if there's space ever for volunteers to talk about these things occasionally, or decompress what they're experiencing in their volunteering with hospice. Is there time for that? And I guess that was my only question. I guess I was going to say death for me is a transitioning to something bigger. And that would be my shortest way of explaining it. I've seen two people pass away, and both were different, and if I could say magical to see kind of the transition.
Mm-hmm.
Okay, thank you so much for your work.
Oh, you're welcome, and thank you for your work. Yes, I like the way that you described it. Death is something bigger, going on to something bigger, and it leaves by leaving it kind of ambiguous to some extent. You're leaving it open to whatever that bigger is. That bigger could mean a lot of different things, and I think that kind of openness that you just shared is the kind of openness that we all need to bring to that sacred space with families and with patients, and to remember that their view is really what is important. You mentioned one other thing, and tell me your name. Is it Amelia? Did I hear that?
Yes,
Yes.
Amelia. Thank
Okay.
you.
So Amelia, you mentioned one other thing which I think is really important, and that is, is there a space for being able to decompress, to be able to discuss work? Now we do that. Charlie and I, the other staff chaplain, we do that with our auxiliary chaplains because we have a quarterly meeting with them, and so we do give them that opportunity. And we try to coach them in the way that we, do this. For one, we don't talk about, we try to not talk in terms of specific names and things like that, but just say, this is kind of the scenario, this was kind of the situation, and to try to give them the opportunity to talk about it, because it is important to talk about this work, because it is hard. It is really, really difficult, hard work. And one of the ways that we get better at it is one, doing the work, but also being able to have a conversation about it. And the professional staff has that ability because we are in the interdisciplinary team together weekly, and also in huddles, and we then have the opportunity to kind of do that, to talk about it, and to share some of our frustrations, concerns, and feelings of, well, I don't think I got that right. and you're always going to have moments like that.
Thank you.
I think where I would talk to the volunteer coordinator about that, and Sue, and find out, if maybe she can come and you can come and share with her, or maybe there can be a space created for that kind of time to debrief.
May I add something, Craig?
What's that?
Can I add something to
Sure.
that? We do, Amelia, and whomever else is curious, we do, as volunteers, get folks together, especially when we were meeting in person. Every couple months, we would have events together, whether it be a continuing education or even just a social, and give folks an opportunity to share experiences and stories, without using patients' names, but just to, celebrate moments together, and also just kind of share in the heartache of moments together. Dawn and Ashboro and Sue and High Point both do that with the different groups of volunteers that we serve, or that serve us. And on occasion, and in particular when COVID is behind us, hopefully we'll be able to do things all together outside of a virtual world and in person. But there's definitely space to unpack things together, because that's important, just as Craig said. So
thanks, Ryan, because honestly, I didn't even think of that, because I thought of that just kind of as education time. But of course, it makes sense that you would also use that time as a time for debriefing and sharing and celebrating. So I'm glad to hear that. And Amelia, I know you're glad to hear that, because that's going to give you the opportunity to do that. So why, one of the other questions I want to ask our volunteers is this, and why have you decided to be involved in working with the dying? Because, that's, I sometimes kind of get, when I think about it, I think, wow, there's so many other places a person could go and give their talents to and things like that. And yet you've decided to come and work with the dying, which is pretty incredible. So I'd love to know if anyone would want to share about what their reasons for that would happen to be.
I would say for me, and I shared a little this morning, that it's because I can, and I don't think there are a lot of people who can.
Right. Meaning, when you say you can, you have the time, or you mean you have the time and the, the kind of the talent, or
Yeah, the ability.
It does take some talent.
Yeah, I think it's about the ability. And maybe the desire, where many people wouldn't want to or be able to.
Okay, and tell me, what is the background that has prepared you for this?
Well, I shared this morning, both my parents died within 4 days of each other some years ago. Wow. And then I had my sister 6 weeks later, which was a triple whammy. And during all that, it made me realize that it's an important role, and maybe it was something I could do.
Wow, sounds like a trial by fire that kind of prepared you to be able to work with us. And I'm sorry that you had so much grief in such a short amount of time, because it's really hard to process those kinds of losses so quickly. But I'm grateful that you're bringing that experience to minister to our families and our patients. Very grateful.
Go ahead, Jan.
For me, I lost my husband a year ago, just about a year and a week ago. And just prior to that, I lost my mother. But I bring to hospice 30 years of volunteer work at Cone Hospital. Part of that time was in the joy of taking baby pictures, although of course there were times when it was taking a picture of a baby who had passed on. And then most of my time at Cone was working with the, as a liaison between the doctors and the surgical teams and families. And I found what I think I brought, my thinking is that my skills might be better used for families who are waiting or in transition, because I found I could bring some calmness to them. You know, frequently people are rattled and it's chaotic when you're in the middle of someone being very sick or dying. And so my job was to try to calm them down, provide resources for them, or just listen. Oftentimes families were angry. They needed to yell at somebody who wasn't going to turn around and yell. But just to be a presence, kind of a strong presence of peacefulness, and a way to say, I hear you, I understand. Let me see what I can do to help you. And sometimes I couldn't, but more than usually I could. And so in my heart, going through this journey the past year, I found that hospice just brought some peace to me when I was going through the loss of my mother and of my husband. And as I began to go down the journey of recovery, I thought, you know, I want to help people. I want to somehow bring them a sense of maybe calm and strength and a listening ear, so that they're not out there floundering around feeling alone.
Well, thank you so much, Jan, because that sounds like you spent a lot of time in hospital waiting rooms with families, and that is such a difficult place for those families to be, to waiting and feeling so uncertain about things. And you, sounds like you provided them with a lot of encouragement and just the presence of someone who cared about what they were going through.
And it gave me a lot of, I felt, gosh, I can't put my finger on the word right now, but I would leave the hospital or the various situations and feel like I had, thank you, God, for the words. And it kind of gave me a feeling of being, helping somebody, you know, being there to fulfill somebody's needs. So that's the strength that I'm hoping I might be able to bring to hospice. It's so new yet that I lost my mom and my husband, that I'm not sure right now I would be the right person to being with them at the deathbed. But I don't know. That's what this training hopefully will tell us each what we can do, what our strengths might be.
Thank you so much, Jan. I appreciate it. So let's take a look at exploring the reality of separation. You know, when you enter the patient's life on this final journey, they're experiencing separation long before physical death takes place. And below, you'll notice that there's some examples there of anticipatory grief. And that is, you know, a lot of people say, well, what's the difference with post-death grief and anticipatory grief? Well, the real big difference is that with the anticipatory grief, the patient is a part of that grieving process. And so think about it in terms of a lot of losses, a lot of limitations. You know, the realization that a person is saying to themselves, I'll be missing out on future milestones. It's the loss of a future. And so you know, you find that a lot of patients are losing their physical strength, sometimes their sight. I've known patients that were weaker, they were blind, they were deaf. You know, I mean, it just, how could it be more overwhelming, you know? And because it's hard, even if you have your sight and your hearing, but to not have that, of course, complicates it that much further. Personal business or occupation, you know, we don't have too many of our patients. We have had a few, but not too many of our patients that are able to hold down their job while going through this process. And it's because it takes such a physical toll on that person. They're just too weak to be able to keep it up. And sometimes also their mental faculties are not quite the same. Their favorite hobby, you know, a lot of times you can't do it. And sometimes they just lose interest in it because things change. Their ability to serve others, I've known that to be one of the hardest things for a lot of people, is that they're used to being the giver and then having to then become the recipient and becoming the one who feels dependent on others. That's a real grief for a lot of people. Can you think of any other examples?
I would say just the ability of movement, driving, freedom to move, transport oneself. That was difficult on my dad. I know he really wanted to drive to see my brother on his birthday, but like couldn't. And I think that it's just so many simple things that we don't even think about, or maybe even movement, around the house, just very small, but very, very big.
Because a lot of our patients, exactly right, a lot of our patients, one of the great griefs is the loss of independence. And they do become extraordinarily debilitated. Many of the patients become very debilitated. And that, can you imagine the feeling of helplessness that creates? And then the great feeling of dependence on others, which is also a real struggle. So let me share how volunteers can maybe help close that gap. You can be a friend to this lonely, it could be a lonely family member, it could be a lonely patient. And they do go through a deep sense, many of our patients, many of our family members go through a deep sense of loneliness because I think of oftentimes as something that I say to people, and I realize, I'm trying to say it in a way that that doesn't make me sound like I'm like I know it all, or like that I really truly understand what they're going through, because I realize I don't. But a lot of times I'll say things like, I can't even imagine what this is like. I say that a lot, and it's true. But I also think to myself sometimes, wow, that must make them feel lonely in this, because I just said to them, I can't imagine what it must be like. And I'm being truthful, but you kind of see my point, is that this dying process can be a lonely situation, because the truth is that we can't really know what the patient is going through, even if we've been through a similar thing, because their situation is unique. So it is lonely. And so having someone who understands, or at least is there as a presence who cares. I may not know what you're going through, but I care deeply about what you're going through. A strength to help to do some things that they can't. I remember this one couple, and they had all kinds of things, and they were in a skilled nursing facility, and they had lots of things that had been brought from an assisted living facility that they used to live in, and they just had it was literally in their room stacked up in garbage bags. And one of the volunteers, this is my patient, and so I asked one of the volunteers to help me to organize their things into tubs so that they could be stacked, and so that they would be able to at least, pull them down and look at them and be in some kind of organized fashion, and not just feel like chaotic kind of circumstances. Besides the fact that it's just space in a skilled nursing facility, of course, is a big issue. And so we were able to help them with that. They could have absolutely never done that on their own. No way. And a volunteer helped me do that. I think it took us about 4 hours. And a listening ear to share their struggles, their hopes, their fears. Listening, oh my goodness, how incredibly important that is. And then a companion to do things with. We have some of our patients, who are at a place where they still can get around, and we have had volunteers, to, I guess you could say, almost, help them do some of those bucket list things, I guess you could say. We had one guy just wanted to fish one last time in in City Lake, which I believe is the Jamestown Lake, if I'm not mistaken. And apparently there's some pretty big bass over there, and he was just hoping that maybe he'd get one more chance to do that, and a volunteer helped him to do that. Watch an old movie, with someone who loves movies. Read a book with someone, who doesn't have the eyesight to do it anymore, but wants to, read To Kill a Mockingbird just one more time. I couldn't get enough times hearing that. So, lots of ways that you can be someone as a volunteer who closes that gap of separation. This next situation, I'm gonna buzz through it pretty quickly. It's talking about pastors versus chaplains, because one of the things that we find is that a lot of people who don't say in the process of admission, sometimes we'll get, well, I have a pastor, why do I need a chaplain? And so one of the ways that we try to help them understand this is that there is a difference. There is a difference in what a pastor does and what a chaplain does. So a chaplain is really a generalist. See all the things that pastor does. Unbelievable number of things. I used to be a pastor, so I know you just have so many different roles in your church. So many things that you're supposed to be good at. And yet a chaplain, on the other hand, they're really specialists, and they specialize in a particular kind of chaplaincy. And the kind of chaplaincy that Charlie and I do is the bottom one, clinical. We are clinical chaplains because we work in a clinical setting. And we are, the thing that is common between us is that we are ordained ministers. We have master's level education, and we share in this same sense of God's calling. And we share a lot of the same tools, scripture and prayer and music and religious rites and rituals and ordinances. So lots of similarities, but also there are some very, very different types of things as well that make it different. And that is that, the chaplain is working as a part of the interdisciplinary team. And so we're talking about, working with folks like the doctor and the nurse practitioner, the nurses, the nurse aides, the social worker. So we work with the whole team in order to accomplish what we're trying to do with the patients and the families, which is to make that person's life as full and as rich as we possibly can, in spite of all that that person is going through. And it takes all of those professionals to make that happen. And there's also a lot of other clinical specialists as well, like music therapists and massage therapists, healing touch therapists and physical therapists. So all of those then become a part of that interdisciplinary team. Now, the work of the chaplain should always be thought of as ecumenical and interfaith. And does anybody have any questions about that? So it's ecumenical and it's interfaith. So that means that that I have patients, sometimes who are Muslim, or Buddhist, or Hindu. Had a friend who had a Rastafarian patient, and actually did the service for that person. It was really interesting. And so, how she utilized her understanding of, and I'm sure in conversation with that patient, what that patient wanted in terms of a end of life service. But so we are ecumenical. So we don't have a particular denomination that we, try to represent. We represent all, denominations in the Christian faith. And we represent, as much as we possibly can with our limited knowledge. We try to also provide care and support to people of other faiths. And sometimes the best way that we can do that is through referral to other faith leaders, a Muslim imam, a Buddhist priest. And there are leaders in the community that are willing to provide that support. But we also have our own resources in case we aren't able to find somebody to provide that support. And we will certainly read from the Quran or from a Muslim prayer. And so we want everyone who we provide care and support to spiritually, we want to do it in as authentic a way possible, a way that represents their own faith perspective. So, already I kind of didn't pop that up. Sorry, I'll give you a few minutes to look at that. Or not a few minutes, a few seconds. And then, so how can I, and we're talking about the volunteer, how can I help my dying patient and their family? How can I do that? One of the ways you can do it is because everybody everybody in hospice is taught to assess for pain. So no one who works for hospice should ever go into a patient's room or home and not, that should really be the first thing that we do after we say hello is, look at that person. If the person's able to answer the question, you just ask, are you hurting today? If the person isn't able, then you make you do an assessment of the nonverbal cues that a person would do if they were hurting. A furrowed brow, a grimace, a lot of movement, which oftentimes is an indication of a person hurting. And so one of the very important things you can do is to be alert to the signs of a person's physical pain. Another thing is to be honest with that person. Be honest with the dying person. I can tell you that I wish it weren't true, but we are asked to lie to patients a lot, and by their families. And I'm not doing it. I'm sorry. I'm not going to do that. And in a way that I explain it to families is that my credibility as the chaplain would be lost if I were to be dishonest with them. And so I can't do that. And some families have decided not to have a chaplain as a result of that. And that's okay, because that is their choice. But being honest, I think, is just so incredibly important, because let's face it, a lot of people talk around patients, and that is sometimes fostered by families and sometimes by medical professionals. And we should be honest with people. Being present as much as possible. And so I'm always careful when I say that, because I know that there are a lot of dedicated, committed people out there. And you obviously are, you wouldn't be volunteers. And so I say that, being present as much as possible, and then I add this caveat, within the limit of good boundaries. Because I know that there are people who would want to, try to be there all the time if at all possible. But we have to also have good boundaries. And volunteers are seeing their patients weekly, which is as often as a lot of patients only see their nurse weekly. Of course, they get more sick, a nurse is going to go more often, but many people who are in a stable situation are seeing their nurse weekly. And so seeing a volunteer weekly, that is a lot. You're getting a lot of time with that patient. And that is to me, I think that is a lot of time. When you look at other members of the interdisciplinary team, a lot of those members are not seeing patients that often. So the fact that you would be seeing that person weekly is, I think, very much being present. Listening, again, very important to listen. And we all, I don't know, I can be a talker. And as someone who can converse pretty easily with people, and I need to always be careful that I'm not filling all of the space in that room with my voice. I need to give space for the patient. And one of the hardest things you'll ever do as a volunteer is to have the courage to just be silent. And that's really hard. Let me just say, that's hard. But I can tell you this, that when you are silent, that's when a lot of the good stuff bubbles up. Is when we give space for silence and then just see what comes out of the mouth of that patient. Pretty amazing. Pretty amazing sometimes. Listening, very important. Offer genuine love to that patient. Be sensitive to when you are wanted and not wanted. And that's really, you know, I know that I have found that that's one of the most important things that I do, is to discern when that patient wants me and when they don't. And some people will tell you, today's not a good day. Thank God. I'm so glad they're able to do that. But some people will not do that. And so it's important for us to be discerning and know when it's important. Not, you know, being there is important, but also knowing when not to be there is just as important. Be patient and understanding about a patient's anger and resentment. So a person may be really angry with God, and it's not our job to tell them that that's a wrong thing. And I doubt seriously that any of you would do that. But it's important for us to be understanding that what they're going through is going to create, sometimes in some patients, some anger and resentment. And we need to just hear it. We need to just be able to hear it. And to be understanding and compassionate towards those folks that are struggling with anger and resentment because of what they're going through. Recognize and be sensitive to the fact that patients and families have their own culture and religious practices. And really one of the, one of the best ways to find that out is just to ask. You know, curiosity, that is not necessarily a bad thing with stuff like that. You know, it's important for us to know our patients and our families. And a lot of them would probably be glad to share, you know, what those cultural and religious practices are that are important to them. And then once we know, then we seek to honor that. And then let the patient die their own death. We have some patients that remain full codes. And, you know, that's dismaying to some people because it's going to look different. You're not going to stay at the hospice home if you're full code. Let me just say that. You're going to end up in the ED. And that really is hard for some people to accept. And yet, it's important to honor a person's wishes. You know, that's, you know, it's not that it's okay for us to educate, but to me, once we've educated that person, you know, a few times regarding that situation, you know, to keep going back to it seems a little bit like harassment. And so we need to honor that person's autonomy to make that decision, even though we might say, that's never something that I would do. It's okay. It doesn't have to be what we believe. And there's lots of other ways to honor a person's death. You know, sometimes people need space to die. And sometimes that's really hard for families. to give the person space to go because they want to be there. Understandably, they don't want the patient to feel abandoned, but you can be present and still give that person space. And you'd be surprised how many people slip off when people just give them a little bit of space to do so. Let's see, we're just 8 minutes away, so we're probably not going to make it through all this stuff, but you all are smart people, so I know that you'll be able to look at these things and get as much as possible from that. As far as the examples, the next examples, I think that you can just read those yourself. They're real easy to look at and kind of see what's going on there. We use the example of a Catholic family and a Muslim family and a Buddhist or a Buddhist patient, a Muslim patient, and a Christian patient who's Catholic. So take a look at that. Let's move to the next one. So cultural effects, the understanding of the meaning of death. And that's so varied. That is so varied for so many people. What does death mean? What's going to happen? One of the things that I will often say to people is that, because I'm trying to address the fear, is I will say, you know, death is falling into the arms of God's love. And I truly, I don't say that tritely. I believe that, absolutely. And I want people to feel, you know, okay about dying, and not to have this terror about dying. And some people do. They really are fearful of death. And sometimes we can't fix that. You know, sometimes we can't fix it. But for me, saying that, I've seen a lot of relieved faces, you know, when I described it that way. But there's lots of very different understandings about the meaning of death. And people bring a lot of their own, you can imagine, belief systems from childhood, theology that sometimes makes them very, very fearful. Rituals of coping with dying process. So reading a sacred text, praying, meditating, family stories. Those are ways, those are rituals to aid in the dying process. I love it when I can get a family just to, you know, I'll say sometimes, well, just tell me a good story about your dad, you know. And I did that, trying to think, I guess it was last Friday with a family. And you could tell, you know, they weren't expecting that. But then once they started talking about it, they told me a bunch of great stories about their father. And you could see that in telling those stories, it was able to help them in their grieving process. Burial and commemoration. So services, or, you know, some people have a service, some people don't have a service. Of course, COVID has changed everything. But some people want burial, some people want cremation. And you know, that may just be a decision for you. Some people, that is monumental. You cannot believe the people that I've had. Is there anything in the scriptures that says that cremation is wrong? Get that question a lot. Really concerned that they're maybe not doing it the right way. A funeral or a celebration of life. So service, no service, burial, cremation, funeral, celebration of life, lots of different ways to look at things. And we need to be aware of those things and help people with the processing if they invite us to do that. Beliefs about an afterlife, resurrection, reincarnation, paradise, punishment, or simply just ceasing to exist. Some people look at it that way. Lots of different views on that. And we need to know what our patients believe about those things so that we can honor those things for them. Mourning and expressions of grief. What is the proper way to mourn? Some people think that stoicism is the only way to mourn. And I'm convinced because it creates less anxiety for them. But the truth is that some people mourn emotively, and it's okay. It's okay for a person to do that. Roles of men and women. Muslim men care for the body of a deceased Muslim man. And that's really important to note, because if we mistakenly sent in a female CNA, that would be dishonoring to that patient and that family. So really, you see the importance. So our people are so smart over there at the hospice home. As soon as they know it's a Muslim patient, they're asking those questions. And they're making sure, is this something, this is our understanding. Is this what you all want? Because very important to do that in a way that honors the family's culture. And those last two, we're going to move on. Because I think that they kind of work into a lot of the things we already said. So we're 2 minutes in until, that spiritual pain is just as real as physical pain. And if you read that, you will see and that it can be extremely a big struggle for people. Symptoms of spiritual pain: unfairness, unworthiness, hopelessness, guilt, confusion, fear. So you see that unfairness, they're asking why. Unworthiness, I don't want to be a burden to people. Hopelessness, what's the point of all this? Has my life mattered? Guilt, is God punishing me for this? Confusion or fear, does God really exist? Is there really a heaven? Will God accept me? So all of these are things that people are struggling with, and our job is to listen, to hear those struggles. Some very helpful suggestions, and be as respectful and affirming of all people's belief systems, religious and non-religious. Inform the volunteer coordinator or chaplain of specific needs of the patient, family for spiritual care. I think that it's always important to start with your volunteer coordinator, and then she will let you know if something needs to be passed on to us. Avoid anything that could be construed as an imposition of your beliefs on that patient and family, and encourage patients and families to reflect upon and draw resources from their spiritual belief practices and disciplines. It's all right to share your own spiritual journey when you're asked. That's appropriate, but not to convert. It's about connection. It's not about conversion. Seek to support yourself, meaning care for yourself. There's going to be times where you might make a visit and you go, that's it for today. I'm done. I'm toast. You got to know when that's true, and you got to be able to care for yourself. And then we can be spiritual without being religious. And I think that that's just a way of saying that really spirituality is what gives that person meaning in their life. And it may be religion, but it also may be something else. And you need to be curious and find out what that is.